So tell us briefly about you and what you do and how you do it. And oh, and by the way, talking about that, that paper I think was a seminal paper. The science one where you co-author in Wuhan. I think that's a great background.
Sure. So I am a professor of environmental health sciences at Columbia University, and I've spent a lot of the last decade developing systems to simulate, understand, and forecast the progression of respiratory viruses. So we've studied a lot of things like influenza, respiratory syncytial virus, and variants of the common cold, which are caused by different etiological agents such as rhinovirus and endemic coronaviruses. We also have looked at the way transmission dynamics of certain pathogens feed into their ability to get around in the community. I've had an active sampling program in New York City where we document what are typically undocumented cases or infections of these respiratory viruses to try to get a sense of how much they're moving around in the community in an undetected way, how much silent transmission there is because people are unwittingly going around while shedding respiratory virus as they shop, go to work, get on public transportation, etc. So we spent a lot of time working on things in a mathematical and computational context, but that latter project I told you about is getting out in the community and directly sampling people, trying to understand what's going on and how things are getting around. Let me tell you a little bit about why we approached COVID-19 and the crisis associated with it the way we did. We were really informed by that sampling project that we had done in the city of New York. We had done a couple of things, one of which was we had gone to a major tourist attraction and we had sampled people who were visiting it. We had basically consented them to participate in our protocol, and then we would take a medical history. We would also ask them how they had felt in terms of 9 different cold and flu symptoms over the previous 48 hours. Those are things like a runny nose, a cough, a sore throat, chills. We would also take a nasopharyngeal swab, and we would take that back to the laboratory and run it through what's called a qPCR assay for 18 different respiratory viruses. Those included many of those things I just referred to, things like influenza, adenovirus, endemic coronaviruses, etc. And what we found is that there is actually a substantial rate of shedding of these viruses as people are walking around at this major tourist attraction in New York City that draws people from all over the country and all over the world, huge swath of people who are just simply shedding respiratory virus, and they may be wholly unaware of it or just have, a little bit of symptoms, but it's not really slowing them down, certainly not enough to stop them from going out and about in New York City. We saw that in the month of February, which is, the heart of the cold and flu season, 1 in 9 persons was shedding a common respiratory virus. It's a very high rate. And to us, that indicated that what we were dealing with was an ability of these viruses to get around in the community simply because they have a protracted infectious period during which your symptoms grow. And for many people, those symptoms never get severe enough, potentially, to actually stop them from going out and about. It doesn't keep them home. So they're out in the community and they're sharing their virus. We had another arm of this study where we enrolled a cohort of people. And these were people who we considered on a recurrent basis. We did this over 2 cold and flu seasons. We had over 200 people enrolled in this study. And what we would ask them to do was to provide us a daily report that they would just deliver in about 30 seconds over their phone into an electronic database that we kept that would document how they felt that day in terms of 9 cold and flu symptoms. Again, things like cough, sore throat, runny nose, etc. They would also tell us if on that day they had stayed home from work because of those symptoms, if they had taken cold or flu medicines because of those symptoms, or if they had seen a doctor because of those symptoms. So we got rates of clinical care on a daily basis. We also, once a week, regardless of how they felt, would swab them and take that back to the lab and test it for common respiratory viruses. And there were a couple of very important things that we discovered from this. First is that there really is no good definition of asymptomatic infection. What we found by seeing people reporting their symptoms on a daily basis, that some people are reporting symptoms every day. They may have chronic rhinitis, they may have seasonal allergies that flare up for months on end, they may have fibromyalgia, they may just be a hypochondriac. We really don't know, but they're reporting symptoms all the time. And then you had other people who would never report symptoms. And so we have this big difference there that makes it very difficult to actually define what an asymptomatic person is. And because of that difficulty, it doesn't actually provide a natural demarcation for deciding, who might be out and about and who might not be. Because there are people who are constantly out and about with what you might consider symptoms, but they're not infected with a respiratory virus. This is just something that they feel and experience on a day-to-day basis. And there are others who never report any symptoms and have these acute respiratory infections, and they spread them out as well. And they may be what you would call truly asymptomatic, but it's not a good dividing line is the point. One of the other things that we saw, though, was that because they were telling us how often they stayed home, and in particular, how often they saw clinical care, we could see what that meant for reporting biases in our standard surveillance systems. So our standard surveillance system for respiratory viruses involves a passive system in which sentinel clinics and hospitals report the fraction of people they're seeing in a given day or given week who are presenting with a particular illness or just influenza-like illness, which is a syndrome that's diagnosed based on having a fever of 100 degrees Fahrenheit or greater and a cough or sore throat. So because it's passive, they're only getting the people who feel bad enough that they decide to go seek medical attention. And that turns out to be a minority of the infections. Even for things as severe as influenza and human metapneumovirus, only a small proportion of people actually went and sought medical attention. 1 in 4, 1 in 5, basically. For some of the more mild viruses, it was 1 in 10 up to 1 in 25 persons would actually go and see a doctor because of this infection. So what we're looking at is a system that only documents a minority of the infections, is only capable of recognizing that they're there because the majority of them don't experience symptoms that are severe enough that they're bothered to go see a doctor. So when this virus came out, we saw that it moved very quickly within China. It spread geographically very quickly within China. And then it began hopping on planes and going to different locations. We could see it go to Thailand and then places in Europe and the US and the rest of Southeast Asia. And that rapid expansion of us rang some alarm bells in our minds, because when we looked at that, we said, this looks a lot like there may be a high rate of undocumented infection. We don't know if they're asymptomatic or mildly symptomatic. We don't really care. It just means that there are people out there during their infection, doing their normal activity, who are shedding this virus and spreading it and taking it to other parts of their local communities and even getting on planes and taking it to new areas entirely. And that rapid spread is a very dangerous thing, because that means it can penetrate very quickly into many of the communities of the world, which of course we have since that time seen actually happened. So what we did was we turned to some of the mathematical modeling methods that we use in my group all the time. And we built what's called a meta-population model. And that's a model that represents many different populations and links them by movement between them. And in each population, there is some progression of the virus through the population based on mathematical equations that allow infected persons to infect susceptible persons upon contact with some sort of force of transmission. We were able to inform this model, to constrain it to be more realistic by doing a couple of things. Firstly, we recognize that all we're actually seeing in case observations for the different cities we're representing in China are confirmed cases. Those are the documented cases. So we want to represent documented cases, but we also want to represent undocumented cases. So we explicitly split them into 2 separate groups and allowed people who became infected to move into one of those 2 groups. But what we don't know is what's the rate at which they're moving it. Is it 1 in 2? Is it 1 in 5 persons who's documented? This is something that we want to infer. We want to estimate this by basically aligning the model's conditions so it can best represent the outbreak as it was observed in confirmed cases across about a 14-day period, and I'll tell you about that in a moment, over 375 cities. So this is one of the things we do. We combine mathematical models with Bayesian inference algorithms, and we use that to try to estimate the critical characteristics that allow that virus to get around in a community, or in this case, a set of communities. So the way we link them, as I said, was by movement between those cities. And to inform that movement, we used cell phone records, the location-based service from big provider in China, things that govern apps that are very popular like WeChat and QQ that have enormous market penetration in Chinese society. So this gives us an estimate of the amount of movement between the cities in the run-up to the Lunar New Year, which was the period of time we were looking at. We looked at cases over a 14-day period, from January 10th to January 23rd. And the reason we chose that period was January 10th is when there was enough activity to really begin following it. There were enough confirmed cases to really see what was going on. And January 23rd was the date at which the Chinese government really cracked down on this virus. They imposed travel restrictions, other control measures, and they changed their protocols for how they went about trying to identify patients by really going after them through contact tracing and aggressive testing. So prior to the 23rd, what we're looking at is the virus moving about through Chinese society in its natural state, if you will. It's moving around relatively unimpeded, as it would if left to its own volition. So we have those case data now for January 10th to 23rd. We have movement data between the cities, and we have this model construct that we built that before applying to the actual data, we test to see whether in a more idealized setting, where we've generated outcomes where we know the solution, it can reconstruct it and estimate those critical features, those critical parameters. Now, the two things that we were really interested in was, can it estimate the fraction of people who are documented, and conversely, the fraction that are undocumented? And can it tell us the relative contagiousness of those undocumented infections? In other words, the people who are undocumented, if they're not contagious, if they're not shedding enough virus to pass it on to anyone, they're basically dead ends. And they really don't matter materially for the transmission of this virus in the community. On the other hand, if they're just as contagious, then that means that there's no difference between a documented and an undocumented infection, who presumably have differences in severity. Presumably the undocumented cases are more mild than some asymptomatic infections. And those might then be shedding just as much as the documented cases. So there might be no relationship between symptom severity and shedding. We don't know that. We want to find that out. So when we ultimately applied this, after validating this model structure and the inference associated with it, when we applied it to the Chinese data, what we found is during that run up to the travel restrictions, we estimated that only 1 in 7 infections was documented. 86% were undocumented. Further, we estimated that about those undocumented infections per person were about half as contagious as each documented infection per person. However, because there's so many more of them, they are responsible for the lion's share of the communication of the virus. The other thing that is important is within our model, we were also able to identify or estimate that there probably is considerable pre-symptomatic shedding. That is, people, even if they become symptomatic and become documented, they are shedding the virus prior to recognizing that they have any symptoms associated with it. And that goes for both the documented and the undocumented infections. The last thing that we did with this system for this period of time prior to the 23rd is we said, well, it's a model. What would happen if instead of these undocumented infections being about half as contagious per person as the documented infections, they weren't contagious at all? What if we shut them off? We can run it in that way. It's a model. And so we shut that off and ran counter simulations. They're called counterfactuals, to see how would this outbreak look like if they weren't able to contribute to the spread of the virus. And what we saw was it was greatly ameliorated. Instead of seeing as many infections as we had before, confirmed cases, that number was reduced by 80%. So again, this points to the idea that this silent or stealth transmission, supported by people who really aren't aware that they have the infection and never will be perhaps, is what allows this virus to go around. Now, this is consistent, I think, with what all of us experience when we go about our lives, particularly if you live in a temperate part of the world and you get sick during the wintertime, and I'm sure in the tropics as well. If you get a respiratory illness and it's mild, maybe you have a little runny nose, your throat's a little sore, it doesn't stop you from going to work. It doesn't stop you from commuting. It doesn't stop you from going shopping. And it doesn't stop you from taking business trips and taking vacations and getting on airplanes and going places. If anything, maybe you'll take some medicine to make it a little easier, but you're going out and about. And the fact is, in those instances, you very well may be shedding virus. And in doing so, you may be spreading it to other people in the communities that you enter and go to.
Wow. Can I ask you a couple questions on that?
Of course.
So I guess the inference about people who present themselves with symptoms that they are more contagious probably relates to viral load, right?
Probably, yeah. That would be the assumption, that there's some positive association between symptom severity and shedding, and that those with more severe symptoms may be more symptomatic because their viral load is higher. They may have gotten an initial infectious dose that was higher, or it may have amplified more efficiently within their systems.
Do you have any sense from your models and from the data actually about how many days pre-symptomatically that people might begin to shed? Is it 2 weeks? Is it 2 days? What does it look like?
Well, we got about 2.5 days in our estimate, and I've seen estimates from 1 to 3 days. And this is in stark contrast to SARS-CoV-2.
Right.
So to SARS-1.
Right.
SARS-1, people didn't shed until they were symptomatic and they really recognized that they were sick. And that was something that probably helped us constrain this virus as well. Further, there are almost no undocumented cases of SARS. By serological assays, they found that they couldn't identify people who hadn't already been confirmed because they were symptomatic and sought medical care, basically, who had SARS-1.
What about on the back end of the illness? How long do you continue to shed after symptoms, or how does one know that viral shedding has basically stopped, and what's a safe zone post?
That's very difficult to say. So let me say specifically how we did it within our model, which doesn't give you a lot of information. So when we used our model, there is a delay between when somebody acquires the infection or transitions from being latent to infectious and being confirmed. So the progression of this disease appears to be you acquire the infection, and initially you are in what's called a latent phase, where the virus is replicating in your body, but it's not at sufficient levels that you're actually shedding it and are contagious. Further, you don't have symptoms at that point. So the virus is basically growing in your body. And that period we estimated is almost 4 days, all right? So let's say it's 3 to 5 days. Then you go through a infectious period where you are contagious, and then you recover. That's how the model represents it. However, in actuality, what happens is there is a pre-symptomatic phase. Then a person, if they become symptomatic, will have their symptoms grow. And then eventually their symptoms are intense enough that they will go to the doctor. That may, that symptom growth phase could be 1 day, could be 7 days. It depends on the progression of the person, right? At that point, they have to be tested. And then that test has to be confirmed. And that doesn't come back for another 3 days, right? So there's a huge lag between infection acquisition and case confirmation, which means that when we see cases that are confirmed, we're actually looking into the past. We're seeing something that reflects cases that were acquired almost 2 weeks ago, 1 to 2 weeks ago. In the context of the model here for what we were dealing with, we had access to some line list data. Line list data is data that shows you for specific patients what happened in their progression. And very often it's incomplete. But for some of them, we had information on the day of symptom onset and the day they were confirmed. And what we could see was that was about 6.5 days in China during that period from January 10th to January 23rd. So that means there was a delay between symptom onset and confirmation of almost a week, just a little bit under it, right? Now, in our model, we're not representing symptoms. Remember, we said we don't want to use this symptom asymptomatic dividing line because we're not going to have information on it. We're going to go with documented and undocumented. But what we do have in the model is a transition, from being latent to being contagious. So we tested the model with several time to event distributional models imposed on top of it. And what that meant is we said, well, it's at least 6.5 days on average, and it follows what's called something called a gamma distribution that determines, when in the future somebody will be infected, will be confirmed. But on top of that, if there's pre-symptomatic shedding, that's what's going to map to that transition from going to latent to infectious in our model. So what we found was the best fitting form of this for our model was when we ran it with a 9-day lag between transitioning from latent to infectious to case confirmation. And because that 9 is different than 6.5, and there's a 2.5-day difference, that means on average there's 2.5 days of pre-symptomatic shedding. That's what we're inferring it from.
Okay, have you had a chance to, people are speaking a lot now about serology.
Yes.
In terms of IgM and IgG, particularly the spiking. How does that relate to the PCR testing and your own view of how effective that the antibody screening can be with respect to determining presence or lack of presence of shedding?
Honestly, David, I haven't read that literature, so I'm not going to be able to comment really effectively on it. So you're talking about using now the serological assays to look at the innate immune response in order to determine whether the acute infection is present, as opposed to any assay to see retrospectively whether antibodies have been generated.
That's right.
Right. Yeah, I haven't seen how that's being used. I don't know that it is as effective. You could actually tell me about it because I haven't heard whether or not that's being actually rolled out yet.
Well, the idea here is, and basically what you've just spoken about, is to get an effective America Back to Work program.
Mm-hmm.
We're really going to need to test and test and test and test. It's
Yes.
inconceivable that we're going to be able to curb this thing without knowing who and where the lines of transmission are and the clusters are.
Right.
And the vast majority of people, in fact, are asymptomatic or have minor symptoms.
Right.
And so the only reasonable answer to all of this is an effective, probably point of care test in some way, shape, or form that can determine fairly immediately who is safe to walk onto a work site or not. And the problem around, the traditional method of testing, looking, the antigen methodology for testing is that it's kind of, nasopharyngeal swabs, difficult, need to have expertise to do it, takes more time in many cases, although there's some
rapid testing developed, but yes, they have sensitivity and specificity issues, of course, as well. Yes.
Right. So what we're really dealing with is, and this is what our employers are asking us, Jeff. How do you safely return to work? And, everybody wants the magic answer to this. And I say, well, there are 3 variables here. One is, rapid test to understand who's shedding, number 1.
Yeah.
Number 2 is, that's necessary but insufficient. Number 2 is understanding what are the relevant social distancing requirements in any given state of endemicity in any community. Namely, it can be much more distant if there's no endemicity, frankly, may not even need testing. And then the third is, you can't do any of this and be successful if you don't have an assiduous public health contact tracing system under it to surround those cases, to exclude them from the workplace, and do everything that you need to do. Right. And so what we're trying to help our employers understand that this is basically public health 101.
Yes. With
a piece of science, and the science being how, in fact, do you get your arms around the vast majority of people who are shedding and you don't know it. That's kind of the equation.
And what you're focusing on is more of an idea to identify people with acute infection. So,
well, not really, just who are shedding virus. The acute
who's shedding, but that's what I mean by acute infection.
Okay.
I mean, they're in their shedding stage. And so your gambit here is that perhaps the serological assays might actually provide a better, more sensitive, specific, and more scalable means of actually providing this real-time information so people could monitor whether or not it's safe for them to go to work.
Well, yeah, and it's actually not on what I try to explain to these employers is they're used to testing. They're brainwashed to thinking that testing is for a diagnostic purpose for an individual. But in public health, of course, the purpose of testing the individual is for the benefit of everybody else. It's not.
Absolutely.
Yeah. So the idea, I'm not interested in getting a confirmatory test of somebody who walks to a work site with a temperature and who's sneezing and has a sore throat, they're not coming in anyway. I'm worried about testing everybody who doesn't have those symptoms.
I totally agree. I totally agree. You know, I want the clarification because people have talked about testing in two capacities. One is to use serological assay of specific antibodies to show whether people have been infected in the past, right?
Yeah.
And that has a number of problems associated with
Right.
it. In a sci-fi world, you know, in a perfect idealized world, you would just every morning get up, breathe into your phone, and it would tell you whether or not you have a whole suite of respiratory infections. Now that's science fiction at the moment, and even more science fiction would be that, you know, the phone then generates a monoclonal antibody that cures you for whatever it is that you got. But what you're asking for is a step back from that would allow people a real-time daily indicator of whether or not they are shedding virus.
Right.
And having that as a means of monitoring their own condition and protecting the public health.
Right.
And the question for doing this would be, can we spin up the capacity to do this?
Right.
Can we distribute it broadly enough? Can we have stations where people would go to that, find out whether they're doing it, and be able to do it on a regular basis, you know, because you're asking people to do it not just once, they're going to have to do it daily or once every other day or something of that nature if you're really going to be catching people in their infectious state, right?
Yeah, well, I have to say that my hypothesis here, and I looked at places like who've done this pretty well, and you know, the Taiwan and Singapore and the like. I think to create the best safe environment is to do it once, and then once you have a good sense that the environment is fairly clean, you could assiduously follow daily temperatures and close contacts and risk, and immediately exclude those people and test those people. I'm not sure you have to keep on testing everybody every other day. You know, I think that the math gets more and more simple once you take out 90% of the burden or 95% of the burden of this stuff floating around from people that you don't know. And
I think, you know, look, I think what you're saying is more practicable, firstly,
right.
because this is sort of the South Korean strategy, which is to be used, you know, aggressive contact tracing and swabbing to make it abundantly available to isolate those who have been infected and quarantine their contacts and go from there. They're also invasive into people's credit cards and where they've been and gone. And that's something that perhaps people in this country are less comfortable with, though I might note your credit cards already have that information, so
well,
they're
your phone,
using it.
Your location.
Yeah, your phone company, your credit cards, they all have this information. So we're probably all fooling ourselves to say that it's not being used and out there. So anyhow, I agree that if we were to get on top of this, we can do that. The critical question is, will we have the capacity to deliver this? And this is something that requires resources and a real rollout of them that will allow us to have enough of these kits, the capacity set up to allow this testing to take place, enough public health workers on this who are monitoring this situation, and the will as a society to actually follow through on this, not to become complacent and to be like, all right, look, we got this. Everybody just go back to work. We need to reboot the economy, because what will probably happen then, because susceptibility is still very likely very high in this country, and there are some minority views that say, well, maybe, you know, it's 1 in 100 people who've actually been documented, so there are tons more infections than we know. I don't think that's probably the case. But, you know, right now in the United States, we're approaching 500,000 people who are confirmed cases. If 1 in 10 of them, and we estimate originally when it was in the US, it was about 1 in 12, but if let's say 1 in 10 or even 1 in 20 of those people are confirmed cases of all the infections are, that means only 10 million people have gotten this thus far, which is a drop in the bucket in terms of developing herd immunity in the society, and means that unimpeded, if we relax our conditions without monitoring it well, this virus will take off like wildfire again.
Right. What do you, by the way, I have another question on IgG, but before that, what is your sense of what the level of herd immunity is required to break transmission? You know, my original research was in measles, and as you probably know, it was, you know, 6% threshold. and boom, you could ignite an epidemic. So herd immunity was required at least at 94%. What is it with these respiratory viruses? Do you know?
It can be lower. It can be much lower. So for something like this, theoretically, it's basically 1 minus 1 over R naught. And so the R naught estimates here are around between 2 and 3 right now. So you're looking at something between 50% to 2/3 of the population has to get it before herd immunity is going to be effective in any particular community. So 33 to 50% is what you're looking at to see some real attenuation.
So a lot of people are throwing around this notion that the appropriate use of serology is just to let people back to the workforce who have demonstrated with a high degree of sensitivity and specificity, obviously, that they have IgG present. And you alluded to the problematic nature of that hypothesis. And I side with you in the sense that that's really not what we want to know today. What we want to know today is a whole other group who are actively shedding, and that it's almost irrelevant, frankly, who is immune, because it doesn't change the dynamic of keeping the workforce safe, particularly when it's the minority of people who will ultimately get the disease and be immune. We're talking 10% levels. Can you just, am I thinking about this correctly? Or, what's your thoughts on this?
Well, it's not going to be, if we manage to stop this with a nominal penetration of our society, such that, on average, maybe 10% of people have been exposed to this, let's say in a whole bunch of weeks when this thing really gets quashed. And then we're looking at an issue where that's not a huge portion of the economy, where if you're only going to let out people who have demonstrated demonstrable antibody evidence of having had an infection, you cannot reboot the US economy using 10% of the workforce. It doesn't work. So you need an additional strategy to let people out. And yes, the best way to do it would be that you need to continue to monitor it. And people who are presenting with infections have to be tested very rapidly, and then you have to quarantine their contacts. And you have to continue to limit social interaction. That we're going to be in a new normal for a while, where mass gatherings aren't going to be allowed because we have too many instances of those being super spreader events, where parties, people get together, and a huge number of people at these events come down with the virus, and then they take it to their communities, etc. We don't want that. And then we're going to have other basic hygiene protocols and distancing and spacing. And people can come up with all sorts of ideas of, maybe people can go to work for a couple days and then they stay home for 5 or 6 or something like that. All sorts of weird ways of going about it. I think we need to have a conversation to consider it. The thing that would best help this, it would be to develop our testing capacity and be willing to use it aggressively for isolation and quarantine purposes. That is the thing that has been shown to work. Particularly, I point to South Korea again. And the reason is they had an outbreak there and they got it under control and they quashed it. And to date, they've been able to keep it down at a really low simmer. And they still have their economy in some form of function that is much greater than what we have right now in the United States, that allows them to go about their commerce and their business. They have a huge preponderance of face mask usage, which I think we should emulate. We don't know how the virus is transmitted, but it seems to me that that's probably better than it is harmful by a long shot. And they're willing to go after people and identify who they've been in contact with in a somewhat invasive fashion to get them to quarantine if they've been in contact with somebody who's infectious. And those measures have allowed them to keep going about their way. Now, I should add, Sweden has a completely different strategy. Sweden has only restricted access recently to assisted living facilities, places where the elderly are, and they restricted, a week or two ago, mass gatherings of 50 or more people. And they refused to shut their economy otherwise, but they've told people to take personal responsibility. Now, the scuttle is that on their subway in Stockholm, the cars are empty, relatively speaking. And a lot of the society has really taken this to heart in terms of commuting and other things of that nature. But then you get shots from the street where there are lots of people around and they're not wearing masks. And when you look at the mortality rate in Sweden versus Norway, it's 10 times higher right now. Right. So you wonder, is this a consequence of what they're trying to do? Right. We also have to wonder, maybe are they doing the right thing and taking a hit like this, not devastating their economy for a prolonged period of time, and seeing what happens. I'm not going to weigh in on the wisdom of that choice, but I'm going to say that what we have is a series of natural, if you will, experiments around the world because different governments are taking different tacks with this. And we need to learn from that. I think the US should be learning from South Korea right now.
Yeah, I agree with you completely. Do you think that it's possible to create an algorithm, although it's not really an algorithm, on a community by community base, where an employer can pull the trigger and say, okay, now if we had the required supportive testing and we had the public health methodology in place for contact tracing, that it's okay to get going and get back to work, that the benefits far outweigh the risks? How do you determine at what part of the curve or what part of the natural incidence it would be required? And is it possible to develop a model? Because that's what the employers are asking us, when.
Right. And this is where I think it has to be. Firstly, I think there's something to discuss of whether employers should be making this decision or public health officials should be making the decision. Because if you allow employers to make the decision, I think you're going to have some actors that are doing phenomenal jobs and being very responsible about it, and some that won't. And we're adding another layer of problem in there.
I just want to say, I planned the pandemic response in 2007 for California, and for the Schwarzenegger administration, and it all began and ended with a command and control from the public health department. Yeah. But unfortunately, everybody's missing in action, for the most part, in most states in the public health arena. I mean,
yeah, I hear you.
We have not been able to count on what you just said.
Exactly, because we have not had consistent messaging, and we have not had clear direction in many. It's just a patchwork.
It's a patchwork.
That aside, to get to your question, is what I think we need to be looking for is there's a factor which you know about, the basic reproductive number. We've referred to it before. It's called R0. And really what we're dealing with ultimately is something that's really called the effective reproductive number, but that's splitting hairs. This reproductive number is a measure of the force of transmission. When it is above 1, it indicates that a person on average is transmitting the virus to more than one person. And as they're transmitting to more than one person, the outbreak is growing. You can just see that. If somebody is it and the R0 is 2, that means they're going to infect 2 people, they're going to infect 4 people and 8 people. It's a growth process, right? What we want is we want R0 to be less than 1, because that means if it's 0.5, I'm going to in fact infect only half a person. So if there are 10 people infected, they're going to infect 5 people, they're going to infect 2 to 3 people. And you can see how the virus is going to be driven to extinction locally because of that. Right. Now, the issue is right now we've had a lot of talk about flattening the curve, bringing it so that we don't see a continued rise in new cases each week. We want to at least get it to the point where it levels off. We need to do more than that. We have to drive it back down. When you have it level, you are at that R0 of 1, and we want it under 1. So here where I am in New York City, we want it under 1 because we need to reduce the number of new cases that are being generated. We need to therefore reduce the burden and demand for hospital beds, ICU beds, and ventilators. And we have to alleviate that strain that currently is exerting pressure on our medical infrastructure here in New York City and the greater metro area for it. We have to pull that back, and we have to do it long enough so we can clear out those hospital beds, not need the extra surge capacity at the moment, and get it tamped down so that the healthcare system can get a breather, doctors, nurses, and other medical personnel can get a rest, and we can get everything organized. That will take not 1 or 2 weeks. That will probably take 3 or 4 weeks to happen if we do this successfully, which I actually think we can. And I think we're on the path to doing that. In the process of doing that, we want to see that R0 well below 1. We don't want it just below 1. We want it crushed. We want it moved significantly below 1. And the reason is by having it well below 1, it gives us the wiggle room to try to go back to work. The idea here is that no matter how effective our testing is, if we could roll out all this testing and we could test people and use the contact tracing effectively, we're still allowing more infection in the community by allowing people to go back to work. and allowing businesses to reopen and allowing the greater mixing that goes on when you have something that resembles normal commerce, right? What will happen in response to that is that the virus will try to take off again. As I said before, there are still a huge number of susceptible people who've never been infected by this virus. And so they are the dry tinder, if you will, the kindling for the fire that allows it to spread. And as long as they're there, if the virus is present in the community and R naught creeps above 1, we will have a problem of growth in cases again. What we would like to do by driving it well below 1 is give ourselves the wiggle room where when we start to go back to work and relax some of our controls and try some things, if R naught jumps up half a point, if we're at 0.3, it will still be under 1 and we will not get that growth. But if we're at 0.9, we're going to shoot up to 1.4 and we're going to have a problem again. And the problem we won't recognize in full for 1 to 2 weeks because there's a delay in the recognition of confirmed cases. So I think the need here is to really clamp down and show in local communities that R naught was really effectively well below 1, that the social distancing was incredibly effective. At that point, if the hospital systems in the community are at a decent place, you say, okay, let's try to do something that will bring people back to work. And we may have to take baby steps. We may have to do it in a tiered way that brings people back in very small increments so as not to do something that would be catastrophic and take us back to square 1.
So Jeff, how can one rapidly assess what R naught is in any given community? Is it a function of the declining admission rates? Is it statistical sampling of testing? How do you get to that piece of information?
Well, you would use observations. You would use confirmed cases. You would use hospitalizations, perhaps ICU bed demands. Now, the problem, of course, is all these data are quite noisy and they have fluctuating biases due to the fact that testing capacity and testing practices have shifted over time. That makes it challenging, but we can work around that. Certainly, when you see a declining number of cases from week to week, provided there haven't been some radical misuse of tests where they're not being used, or they had been used abundantly and then suddenly they're not being used, which I don't think will happen now. You're going to recognize that you're in a declining phase, and that as the outbreak is diminishing, that is indicative of a drop in R naught to levels below 1. What we'd like to do is quantify that, though, and we can do that using various statistical and mathematical approaches. And you will look at it, you try to use a number of those approaches and estimate where it is. And look, what you're looking for is something that is not in the ballpark of 0.9, 0.8, where some of them are estimating, some models may estimate, oh, it's 0.5, but others are estimating maybe it's 0.9 or just at 1 or something like that. You'd like to see consistent agreement where they're saying, well, the models are saying it's between 0.2 and 0.5, right? Then you'd have some sense that, okay, we're probably substantially below 1. We have that wiggle room with which to actually experiment and try to reboot the economy in a certain way. But again, I would say the way we reboot it should really be fashioned off of the success stories that we see in other parts of the world. Places like South Korea, Singapore, Taiwan.
Right. And it's basic public health 101 in an R naught less than 1 environment with heavy testing.
Yep.
That's what you need to do.
Yep.
So, unfortunately, I keep using this, but it's the old Jerry Garcia expression. It's really pathetic that, he says it's unbelievable that nobody's doing this, and it's really pathetic that it has to be us. But the fact is that public health really hasn't stepped up to this in a concerted effort around the country, and unfortunately that's what the lack of leadership has left us with. And what we're trying to do as a company is to step in, particularly for employers who dominate many of these communities with respect to, we have some companies who basically own the company they own the town factory, if you know what I mean.
Right.
And I do think that they have a community role to play if they do this pretty thoughtfully. They can, one by one, come together and frankly, squash this thing out and get the economy back to work. We've been telling people that, you do it well. It's just not about keeping your work site safe. It's about, the intake questions we're asking is who lives in your household, and doing assiduous contact tracing, not just at the work site, but to public health authorities back into people's homes. and into the community. And I don't know any other way, in the absence of public health leadership of this type, to move this along. I don't know if I'm dreaming or not, but I don't know, there's nothing else happening that I can.
No, because if you don't look at it this way, you're basically stuck between a rock and a hard place, and you will go somewhat crazy. Trust me, I've felt it. You feel, and you stare at this problem long enough, and you're like, well, we either wreck the economy or we wreck people's lives in the healthcare system, and a lot of people die. I think there is a constructive in between, and the fact that other societies are demonstrating it can be done requires us to really look at them and to follow their methods and to follow what has been successful there, and to recognize that this may be an invasion of our civil liberties in a way that we don't necessarily feel comfortable. And it's why I point out that the credit card companies and your phone company and a lot of companies, your medical billing record companies, they have this information already. It's the fine print we all sign off on. And maybe we need to just get over it for a little bit and understand that if we're going to allow government public health officials access to it, that they're going to be doing something that is really vital and for public good, and that we have to let them do that in this extraordinary situation. Once we get through this, ultimately we develop some therapeutic or vaccine in a year or so, and we can clear this all out, and we know that people aren't being reinfected over and over again, and we can manage all the death associated with it. We can reevaluate this and decide how we want to think about civil liberties in our society. But right now, we really need leadership to say, look, this is the hard choice we have to do. We do not want to wreck the economy. We do not want to see lots of people dying. If South Korea can maintain their economy while invading people's civil liberties to an extent that we're typically uncomfortable here, but which our corporations already are doing, okay? Why don't we do that if that allows us to get by while minimizing death, while minimizing suffering, while alleviating the strain on our healthcare systems, and allowing the economy to function at a semi-normal pace?
Okay, we have just a couple minutes left. Can I just share with you an idea that I just want to test on you, because people, and it really speaks to the end of the epidemic and when that happens. And you hear Dr. Fauci, who, enormous respect for, say, this thing finally ends when we have an effective vaccine. But, that's not really the way I personally look at it. I think this ends when we have herd immunity, and herd immunity can be natural, it can be passive immunity, or it can be immunity generated by a vaccine. And, having done a lot of modeling with respect to policy as it relates, and I did this for HIV, I did this obviously for measles and others, it seems to me that obviously the most effective immunity is likely natural immunity, and the quickest. And the real strategy and focus ought to be on a potent antiviral therapy for the 10% who do get sick, and for whom we can impede any or the vast majority of morbidity and mortality. And once that happens, then we shouldn't be afraid of the natural immunity being circulated in the environment. And that, to me, feels, considering that there were a lot of studies of post-SARS, there were a lot of labs looking at very interesting antiviral therapies, which potentially could be a much more short-term, i.e. 3 to 6 month intervention, as opposed to the long-term testing of 12 to 18 months to try and achieve, artificial immunity in the community. And I think about this from a policy point of view, and I say, okay, step one here is what we've just talked about, how to finally get people back to work with assiduous public health activities, but then really focusing as an important part, less on a vaccine, which I think is a 30% chance of success, versus really potent antivirals and bringing them to the marketplace, to then allowing a more natural immunity and herd immunity to develop. Am I off my rocker here?
No. Look, I think your assessment of what we're after is absolutely correct. We want to deplete susceptibles in the population, be it through natural infection or through herd immunity, or, as you say, passive immunotherapy of some sort, right? We need to have that happen. That is the only way that we don't have that that tinder to support this outbreak from continuing. In terms of where to go, I agree that, it's a better quick fix if we could have an effective antiviral therapeutic, something that prevents people from needing critical care, from dying from this, would mean that it's okay for most of us to get infected and we could go back to work because we have an abundant, effective treatment that's safe to use. And obviously, this is why people are grasping at things like, chloroquine, and the latest one was some really interesting results with ivermectin. Those are things that are off the shelf, being used off label, that might have some potency against this, that really do need to be investigated, as well as developing it. I don't think, however, that we want to put all our eggs in that only basket. I think there is enough scientific capacity out there to pursue aggressively both a vaccine and these antiviral therapeutics.
What about your thought of passive immunity? I mean, in the old days when I used to travel, before we had a hepatitis A vaccine, I used to get a big shot, of IgG. It would last for 2 or 3 months. I have no idea what's happening in that domain.
People are trying it. I know lots of labs that have been trying it. I don't know what the latest results are and how effective it is. I do know people are asked to donate plasma so that they can, who've been infected, so that they can actually use that. And I have not heard how effective it has been. I don't know whether or not there's been success with that, and it takes a while to document that in some ways, but we can see. We'll see.
Anyway, I cannot tell you how valuable this has been to me personally, Jeff. I have to tell you, this is probably the best hour I've spent in the past 4 weeks with an expert.
No.
Talking about how this has come about. And I just think that this is fantastic. And I think the more that you can, the way you explain this in this very simple and cogent way, I think it's a really great level set. And I'm just delighted and really thankful that you were able to take the time to do this.
All right.